Good evening, all of you, and apologies for not being able to be present in person. I thank the organizers for this opportunity. Well, in coming 5 minutes, I'll be taking you through what is the role of immunotherapy in the peri-operative setting of head and neck cancer. As you can see, the topic, I think Dr. Shashank has spoken nicely for chemotherapy, and let me take you through how immunotherapy causes difference in the peri-op setting. So I initially Googled, peri-operative chemo in head and neck cancer. Once I Googled, I will just display the first 3 pages, what got displayed in Google. And you can see there is a first article in 1988, peri-operative chemo in head and neck cancer in the second. The first is the AI. And then the second article is Pembrolizumab's peri-operative power in head and neck cancer. And then there are a few more articles on chemotherapy in head and neck cancer, perioperative chemo with paclitaxel, and so on. So out of 3 pages, you can see only one article mentioning on perioperative chemo. And the second article itself mentions the power of immunotherapy. So this is the first article which I just opened, the 1988 article. Just look into the last line. The final analysis of perioperative chemo demonstrates no benefit in survival if you use perioperative chemo for advanced age and resectable head neck squamous carcinoma. So this is the paper 1988 said that periop chemo has no benefit. This is the second chemotherapy article which I just opened. This is a study, this is a meta-analysis of 5,000 patients, says concurrent chemo is good, is beneficial, whereas the role of induction chemo has yet to be determined as it did not improve overall survival. So neoadjuvant induction did not work. Now let me take you through the MEC-NC meta-analysis. What does it say? It says concurrent chemo radiation. There is an absolute improvement in overall survival, 5 years of 6.5% and 10 years at 3.6%. Induction chemo, no overall survival benefit. Adjuvant chemo, no overall survival benefit. Peri-op chemotherapy, there is no such mention about peri-op. So induction, no benefit. Adjuvant, no benefit. Peri-op, no mention. Only concurrent chemo, there is an absolute OS difference. Let me take you through the 4 main trials of concurrent chemo radiation versus induction chemo followed by concurrent chemo radiation. So we have all the trials from Europe. The Spanish trial, which was well designed with a cisplatin RT in the chemo radiation arm, it clearly said no difference in survival. And the induction chemo arm couldn't complete the whole protocol because of more treatment toxicity. Italian trial did say that induction chemo improved overall survival, provided the comparator arm was weak. That is, if you use cetuximab instead of cisplatin, then only OS benefit is there. And then comes the DECIDE trial. DECIDE trial said there is no OS difference, high induction chemo-related mortality. French also said no difference in OS and PFS. So repeatedly, induction chemo followed by CTRT has not shown survival benefit. Therefore, induction chemo is not the standard of care for all patients, only in very selected with N2, N3 disease, heavy disease burden, borderline resectable, only there you have value. Otherwise, routinely induction chemo is not recommended. Now I will take you through some important endpoints of immunotherapy. So there is something called major pathological response. More than 90% necrosis is major pathological response. Partial pathological response is 20 to 90. So if you have a MPR or a PPR, your disease-free survival is better. So therefore, these MPR and PPR are good surrogates for DFS. Similarly, I will show you the risk. What is risk? Post chemo, neoadjuvant therapy, if I operate, if there is extranodal extension or margin positivity in the lymph nodes, then it is a high risk. So if you have a high risk versus a intermediate or a low risk, definitely a high risk will survive less. That means the risks also reflect disease-free and overall survival. Therefore, when I give some neoadjuvant therapy, and if I have more low-risk patients, that means my neoadjuvant is working as a surrogates for overall survival. Okay. So before I go into the pembrolizumab peri-op space, let me go through some durvalumab tremelimumab studies. There are studies where IO is feasible and it improves disease-free survival and the major pathological responses. Similarly, Ipi-Nivo also has shown better MPRs. So MPR of 35%. Okay, so having response is a surrogate for better DFS and better overall survival. Now coming on to the main study, Keynote 689. So just look at the eligibility criteria. Adults with resectable head and neck cancer. It included oral cavity, also oropharynx. And then you have stage 3, 4A disease. Randomization as initially you'll receive 2 cycles of pembrolizumab in the neoadjuvant phase. And then surgery and then pembro with radiation, with or without chemo, depending on the risk. And then you have adjuvant pembro of 12 cycles. This is 1 year of pembrolizumab treatment versus surgery followed by radiation with or without chemo. The primary endpoint being event-free survival. Secondary endpoints are pathological complete response, MPR. So let me take you through the demographics. Very important is if I give immunotherapy 2 cycles, that doesn't mean they're progressing and less number of people are undergoing surgery. In fact, the number of people who underwent surgery are equal in both pembro and also standard of care. That means giving 2 cycles of neoadjuvant pembro does not mean that they're becoming inoperable in this period. Good number, equal number of patients are undergoing surgery. Completion of surgery is equal in both arms. Very important is the post-operative risk assessment. You can clearly see the high risk features are less in the pembro arm versus the standard of care arm. That means they are surrogates for better DFS and OS. This is the primary endpoint of EFS in CPS more than 10. Fantastic difference, early separation happening, consistent separation happening, and you can see the p-value impressive. Hazard ratio is 0.66. Fantastic data. This is the EFS in ITT or all participants. Even here, the difference is good. Hazard ratio 0.73, 51 months event-free survival versus 30 months, almost 20 months addition. It is not a minor benefit which we can disregard. It's a significant benefit and it is likely it will translate to overall survival on maturity. So you can see the forest plot, almost all the subgroups are benefiting, right? It is towards the left. So irrespective of PDL1, irrespective of stage, all of them are benefiting. The summary of this trial said that for the first time, you have peri-op pembrolizumab, improved EFS, which is unprecedented in the last 20 to 30 years. And OS did not meet in the first interim analysis, but a mature data is required. So neoadjuvant pembrolizumab did not alter surgery completion rate, and there were more number of people who were at a lower risk, and the adverse events were as expected. So this is the CTRT trial. I mean, that means if I put immunotherapy with radiation, there is no benefit. Javelin or Keynote 412, no benefit. So therefore, you need to place immunotherapy wisely. So what are the important points of peri-op immuno? You need to give neoadjuvant immuno, okay, before surgery where disease is there to prime the immune system. A surgical debulking to make the tumor environment favorable is required. Adjuvant pembrolizumab is very important. You need to strategically place it post-surgery. A peri-operative IO strategy and a biomarker guidance are very important. This is why this particular trial is positive and not the concurrent radiation with immunotherapy one. So what is the conclusion? Peri-op chemo has no mention in any guidelines. It is a failed strategy. Timing matters. Immunotherapy in the peri-op space is important. Biological modification of the tumor microenvironment matters. And the strategy, a smarter trial design are changing the game. This is a slide I took from Dr. Randeep from the OBTO. So if I had to say in 2019 that neoadjuvant nivolumab is standard of care in the NSCLC setting, locally advanced setting, would you believe? You wouldn't have believed. So in 2025, there is early report saying that there is an excellent EFS benefit. By the next icon, I'm sure that peri-op immuno would be standard of care in locally advanced head and neck cancer. So there were people who were making fun that we have Rafale jets, which are not meant to be used for effective purposes. And today we know. So immunotherapy is showing excellent promise in the head and neck cancer perioperative phase. Thank you.